Welcome. I'm Dr. Orlando Landrum from Cutting Edge Pain Relief, and on this channel, we attempt to be able to help patients understand what their pain issues are, provide insight into new treatments and how they might be of benefit, and help you really be able to weigh and make decisions about how you can be able to improve your pain, improve your functionality, and really how to be able to get back to leading the life that you deserve. Today, we're talking about a new innovative procedure that really hasn't been prominently put out there for many pain physicians, certainly for most primary care physicians, and for many pain patients. And it's a procedure that's called Intracept. It's a different premise on how to be able to deal with pain than has commonly been considered. Normally, when we talk about pain, we talk about it being maybe due to a disc, possibly being due to the facet joints, or the joints that allow for us to have mobility. Maybe it's because of a nerve, or like we had a discussion about last week, maybe it's due to the muscle. But what we're talking about today is maybe it's actually integral to the bone, and the bone that has innervation or nerve supply to it. So stay tuned for me to be able to kind of explain to you a little bit and field some of your questions about how this new innovative treatment may provide some potential value. So Intracept itself is a treatment for something that is called the basovertebral nerve. I know, easy for me to say, but as you know, we are going to break this down for your easy understanding and conceptualization of what exactly does that mean. So to me, as has been mentioned many times before, a picture is worth 1,000 words. And so that's what we're going to do. We're going to use a lot of pictures so you can be able to understand exactly what we're talking about. So if you take a look here, you can be able to see that that context of that bone, if you look right in the center that's highlighted with the blue, it basically shows that nerve supply that sits right in the center. So above it, above that circle is that disc, and then the area of the bone. And that bone has kind of like this hourglass shape of this nerve that comes in from the far right-hand side within this distribution of nerves. So the nerve goes up and it goes down. So where it widens out is something that's called the end plate. And the end plate is kind of, if you imagine this is a cylinder, like a can of Coke. At the ends, those ends have innervation. And that innervation is considered possibly the reason for why we have pain that we think might be associated with the disc, but maybe it's not so much disc related. And when those end plates are damaged, as you can kind of see in that point number 2, it can cause a whole host of different challenges, including chronic pain. And so when those end plates are damaged, it basically results in something that is called a modic change. So we're going to explain to you what a modic change is. We're going to give you that insight so that when and if you actually take a look at your MRI or x-rays, you can be able to identify what that is and see, does this fit me? Because at the end of the day, what we want to know is, yeah, it's interesting to learn about new techniques and treatments, but what I want is to feel better. And I really want to be able to lead my life the way that I want to be able to lead it. So in order to do that, one of the things we want to do is to give you insight about figuring out, is this a fit for you? And if so, how can you then be able to kind of move forward with getting that type of treatment? So what is a modic change? A modic change, as I made mention of before, is a change in the end plate. So if we were to pop up a picture like this, you can see a type 1 type modic change. So right now you're looking at a picture of the lumbar spine, and it looks at what is a darker gray coloration where you can see the arrows that highlight, or lighter coloration that you can see where it highlights this change in the bone. So let me give you perspective and context and show you exactly what that means. So when we're looking at a spine, right? And instead of us looking at this kind of like straight on, we're looking at this turned to the side. And what we're identifying is this area of the bone, which is in the center. And then we're looking at the edges, the end plate here and the end plate here, and how that interfaces with the area of the disc. Historically, we thought, well, degenerative disc disease and maybe discogenic issues are causing some of the pain that stays right in my back. It doesn't go down the legs. It stays in my back. It doesn't move. It's sometimes worse. Maybe it's the disc. Now there's some thoughts that are kind of pushing the envelope, that are pushing the edge to say, maybe it's not. Maybe it's the area that connects to the disc, which is the end plates. And so when you look at these end plates, they can have different changes on imaging, where you can see either differences in coloration, which is indicative of something that's called edema, or increased fluid gain into that area, that region, which is suggestive of there being trauma. Or you can see different other types of elements that where you can see actual changes to the bone, where you have little cutaways or little pieces that seem to be chipped out, or quote unquote invaginations that occur. And so what most patients would say is, well, heck, if that's happening, why is that taking place? So let's give you an explanation for that. So when we take a look and we're looking at this is histological slide. So what does that mean? It's meaning we took actual components of different parts of the spine and they stained it to see what are the changes and what are they caused by and what's the speculation of how and or why this is happening. So what we see is that those discs over a period of time become less supple, and that bending has a change that looks different to the different parts of the disc. As we've commented previously, we've talked about those discs having two parts, something that's called the annulus and something that's called the nucleus pulposus, right? And what ends up happening is originally some of those forces that take place in the spine were able to be distributed predominantly to that harder, more firmer component, which is that annulus. But eventually, that nucleus pressure ends up resulting in causing different problems that then result in potential changes to the end plate. And you can kind of see this distribution of the red dot out where the annulus is, and then you can see it distributed to the elements of the bone or that end plate in the center that then causes changes that can occur. So when those changes occur, those changes can result in pain because of that innervation or that nerve to the areas of the end plate of the bone. Again, to kind of reiterate, what that means is if you're looking at the context of the spine, right, and you identify it's on the top or it's on the bottom where you've had a change that's taken place because of the pressure, that can give you pain that stays axial, meaning it's in the spine and it doesn't move off into the legs or other areas. So we're going to deal with some questions in just 1 second. And I know we have one that's coming up. But what some people will say is, so, well, what part of the back is this susceptible to? Now, this particular procedure is indicated from L3 to S1. So when we talk about that, just to kind of give you context of exactly where that is in the spine, we're talking specifically the lumbar region. And when we talk about the lumbar region, what we're looking at is normally okay, I think we're back. If we're back, please send me something in the comments so that you guys are getting this. So sorry about that. Basically, what we're doing is we're looking at the areas from L3 to S1. So when we look at the lumbar spine, what that includes is the following. So lumbar spine, if this is the evidence of a model of the spine, thank you for letting me know. This area from here is L5, L4, L3, L2, L1, right? So we're looking at that lower levels from L3, L4, and L5 currently to be able to identify and be able to treat. Now, there may be some further advancements in that, but right now this procedure is indicated for those levels. So the very lower portion of the lumbar region. So when we talk about that, what many people want to know is, so why are those areas susceptible? And although this graphical representation is going to look very sciencey, bear with me because I'm going to explain it to you. So what you can see when you take a look at this picture is the following. You can see graphs that are present in 4 different areas. And those 4 different areas of graphs basically show the following. The first and the top hand corner basically talks about the end plate and its likelihood of erosions, and it gives you an idea about which levels are more likely. And as you can kind of see that, you can see that the L3 and specifically L4 and L5 give you quite a bit of issue. What we see as we take a look, when we look at range of motion, is we see the range of motion increases as you get further down into the lumbar region at L4 and L5, right? So that's kind of the graph in the top left-hand corner and top right-hand corner. When you go to the bottom, or the bottom left and the bottom right-hand corner, what you look at is the prevalence of Schmorl's nodes. Easy for me to say, I know, but bear with me. So Schmorl's is kind of similar to that mode exchange or invaginations. You can see it's very prominent in the thoracic region, and you can see that it's different depending upon the lumbar region and how that relates to trabecular bone density. So what that means is, if you can be able to kind of pick this out, is that the changes that occur in the upper spine are secondary to Schmorl's nodes, and that's due to a decrease in trabecular bone density. And when you talk about the lower lumbar spine and why there's an increase, it has to do with the increase in the range of motion. So those things really kind of suggest why you get this problem and an issue. So I want you to understand that, because if you don't understand the why, then many times you don't understand what is the treatment and how that potentially benefits you. So we're going to explain exactly what the treatment is, and more importantly, also give you, well, if it works, how well does it work and how safe is it? Because those are the things that we really want to know. We want to know not just does it work, but will it work, will it last, and will it potentially cause me some problems, right? So let's talk about exactly what's done. So how the procedure is done is the following. So this vantage point is looking down at the vertebral body or the spine. So let me kind of give you that orientation so you can understand exactly what I'm talking about. One second, let's pop back. So if again, we're looking at the spine like this, right? What you're taking a look at is you're seeing this end on. So you're able to kind of be able to make out, okay, well, I'm taking a look and I can be able to see where that needle is entering in from. And I know that it's entering in from the posterior elements to be able to address and get into the bone to then be able to get into the vertebral body. Okay, so that's what we're looking at when we take a look at this picture. Okay, so when we look at this, it says accessing the pedicle. So we use fluoroscopic guidance, which basically means live x-ray, to be able to introduce a small tube that has a hole in it. So it's kind of like a straw. And people would say, well, man, that sounds really significant and that might be really troublesome. Truth be told, we use this same type of procedure to be able to do something that's called a vertebroplasty or kyphoplasty, and that type of procedure has been out for easily 3 decades, if not longer, in terms of treatment options for being able to deal with something that's called a vertebral compression fracture. If you're interested in that, we have a number of videos on our YouTube channel that talk about that. But it basically uses technology that has previously existed to be able to treat the problem differently. If you look at this picture, you can see in the center this array of yellow fibrous type things that look like sometimes those balls that you could see where you touch it and your hair sort of stands on end. Well, that is the arborization of those nerve fibers that innervate that element of the end plate like we talked about before. So you introduce a small tube to try to get close. And then once you have that tube, you're going to create a channel and you use the curved areas to be able to get to that basovertebral nerve. So once you're able to get this area close to the basovertebral nerve, what you do next is that you do the following. You basically place a probe there that uses radio frequency close to the area of the nerve. And when you place that radio frequency probe there, you finally apply heat. And when you apply heat there, it stops that nerve potential function from occurring. So most people are like, oh my gosh, that sounds just horrific. To be frank with you, we've done the same thing to be able to deal with facet joint pain. And we've done it for decades. The difference is the length of duration of action. So if you've had fancy terminology, rhizotomy, radiofrequency ablation, or as some people utilize, which makes my skin kind of crawl, burning of the nerves, it's been used mainly to address the joint. This is addressing the pain that's deeper. So if you've had a radiofrequency of the joint, you know that its length of action, meaning how long it'll last, is short in duration. It normally will give you anywhere from maybe 6 months to 9 months, or potentially if you're using something that's different and longer and more sustainable, maybe you get 12 months, unless you do it differently, which is actually one of our videos on our YouTube channel that's upcoming in probably the next couple of days. That's talking about rhizotomy that's not percutaneous. Fancy words for saying there's more than one way to skin a cat, as my dad would say. And so there are ways to make your rhizotomy or radiofrequency of the joints last longer. Kind of a little teaser. You want to check that video out. But this actually lets last way longer. And it's for a different indication, which we're going to get into. But at the end of the day, that's how this is done. It marries two different previously used technologies in a different way. So it marries the entry into the bone by using the same way we would go in by using a vertebroplasty or kyphoplasty. But instead of us putting cement in the back, as you would commonly hear, instead we apply heat. And that heat normally is applied to the facet joint. But for this, we're applying it to the nerve of the bone itself and the end plates that more than likely suggest pain that's associated with that disc, right? So one of the questions is the following, is how much degeneration has to have happened for a person to undergo this procedure about the level of pain that the person is experiencing? So it's an interesting question. And I'm going to cover this in just a second about who is a candidate. But what you would think is that you have to have the significant degeneration that takes place in order for you then to be a candidate for this, and it's really severe. It doesn't necessarily work that way. What is going to be the main indication is, number one, for insurance coverage, because this is covered by insurance, which I have a number of patients are like, you know, I don't know if this is going to be an option if it's not insurance coverage, but there's insurance coverage, but there's a number of steps that have to be taken in order to be able to make sure that this is going to be feasible and workable. Is that you have to, number one, have had the pain for 6 months, which most patients have when they come to me and other physicians like myself. You traditionally have had that pain for a period of time. And during that 6 months, you have to have tried other treatment options. Once you have those two things in place, it's a mixture of understanding, one, is your pain predominantly almost 100% based in the axial region? Meaning, is that pain localized to the back and it's not going down the leg? If it is going down the leg, you need to try and treat that with some other things first. And then on top of that, do you have those radiographic indications, those modic changes that I initially led with that show on imaging why you have the problem? And there's a reason for it, because this procedure originally was developed by an orthopedic surgeon that used the clinical evidence from the imaging to be able to look at how good our outcomes were going to be. So if you have those two things in conjunction, then you're a potential candidate. But we're going to talk about that with a little bit more depth and detail, right? So is it an option for you? As I stated, number one, have you had chronic back pain? And if so, really, have you been dealing with that for at least 6 months? And during that time, have you tried quote unquote conservative care for 6 months and the relief hasn't lasted? So that's what we're looking for when we take a look at figuring out, is this an option for you? So let's say that you are a candidate. Now you really want to know is, well, how well does it work and is it safe? So let's talk about that. So this is based on over 30 years of research, and this is straight from the Intracept site, right? These aren't numbers that I made up or I just kind of like said, oh, I'm going to just pull this out of the blue. No, these are actual numbers that really you can be able to kind of hang your hat on. Nearly 80% of patients in a recent long-term study would have the same procedure over again, And after 5 years, 65% of patients have reported they had resumed the level of activity that they enjoyed prior to low back pain starting in a recent study. So let me repeat that again. 65% had returned to the level of activity that they had before back pain. And then we wanted to talk about, is it safe? Less than 0.3% had a rate of serious complications reported. So 1% would be 1 in 100. This is less than 1 in 100. We talk about complications. We can give you some identification of exactly what that means. But basically, we have research data that's been ongoing and giving support to this for greater than 20 plus years, almost 30 years. We have 80% of patients that say, I would do this again over in a heartbeat. We have patients that would say that their pain relief is 65% of patients, close to 70%, have returned to their activity prior to them having back pain, and they have serious complications of less than 1 in 100. As a procedure, there's very few things that really mimic this. But at the end of the day, we want to kind of delve into that data even a little bit more about saying, okay, so what does that mean when we get and we drill down at having a better understanding? So let's talk about this. So functional improvement. So at the end of the day, we want to have pain relief, but that doesn't mean anything if you can't do anything with it. So let's say that you had pain relief and it took you from, on a pain scale score, from 0 to 10 down to a 1, right? But then you had to sit around on the couch and you couldn't do anything. What good is that? That doesn't really help you. It doesn't let you do what you want to do. You can't go and go shopping. You can't go and go hiking. You can't go and go play with your kids or your grandkids. You can't do anything. That's not any value. What we want is knowing what's your functional improvement that lets you be able to do the things that you want to be able to do. So functional improvement. Functional improvement, what they have seen and what they always do is to take a look at this compared to 5 years. So we're not looking for a quick fix. And what they see is that it was able to improve it significantly, statistically significantly, so that there was an improvement in functional capacity. Huge. Let's take a look at the context of pain. They're able to take that pain reduction and take someone from a 6.7 down to a 2.3. And that was sustainable over 5 years. And I think for those patients of mine that I know, if we could talk about taking you from a 7 or a 6 down to a 2, they take that in a heartbeat, particularly with a complication rate that's less than 1 in 100, right? And then we talk about fewer injections. You know, I know a number of patients that don't love to get injections at all if they could be able to avoid it. And what this procedure was looking at is, so do you have to have other things constantly supplementing this? And what they saw is that at 5 years post-procedure, 93% had not had to have consistent, recurrent injections in order to continue to be able to have pain relief. And then finally, kind of the piece de resistance is that most patients had a reduction in pain opioid utilization, and that 73% patients were actively had a reduction in their pain medicine utilization. And many patients would say that's one of the ways that they would kind of characterize, you know what, is this really working for me? If I know that I can be able to use my medicine less or not need it at all, now you're really giving me some insight about how well this is working and the type of benefit that I'm getting. So let's deal with some of the questions that are kind of coming in, right? One of the questions is, and how many times does the procedure have to be done before relief is felt? So yeah, this is different than radiofrequency ablation. Normally when you think about radiofrequency ablation, you have to do these diagnostic blockades in order to be able to assess it. You don't do that. Here, the major element of assessing and evaluating is, have you had the pain for 6 months? Have you tried conservative care? Do you have radiographs that match those modic changes that we talked about previously? And then following that is fighting the insurance battle. And once you have that insurance battle dealt with, you go straight for the procedure. And all those different studies and numbers that I just quoted was procedure, one and done, and then evaluating it 5 years out. So it's not a recurrent battle of saying, okay, we're going to do it again, we're going to do it again, we're going to do it again. No, it's a one and done in being able to then assess how things go from there. There's no implantable device. There's no neuromodulation. There's no other things that you have to kind of add. It's go after the nerve and knock it out, and then hopefully be able to get you some improved pain relief from there. So, but let me give you context and understanding. If you have other pain issues, or if for my personal patients, as we talk about buckets, right, where you have a facet problem, or you have, spinal stenosis type problems, this is not going to improve that. Those things need to be treated probably preemptively or treated differently, because this isn't going to be a cure-all. It's not a panacea for everything, but it is a potential treatment for that axial pain that gives you a problem that's just unrelenting, that we thought was maybe a secondary to the disc, but maybe it's not so much disc. Maybe it's more having to deal with end plate problems that are causing issues that can be addressed in a different way and or solution. For those of you who tune into our channel with consistency, you know how to be able to reach us and follow us. For those of you who don't, one of the things that we want to do is to make sure that you know where to find us on the web, and our YouTube channel, where you can be able to find videos like this and be able to go back and reference them at a later point in time, is called Cutting Edge Pain Relief. I would encourage you, if you think that this video is of value or things like this might be of value, please subscribe, so that way you can get notifications of knowing when that video is there, or be able to check it out at a later point in time so you don't have to catch the live stream. For those of you who want to even know more depth and detail about how to be able to take control of your life, how to be able to punch pain in the face and get back to leading the life that you deserve, sign up for our newsletter. Because our newsletter not only tells you about our videos, but it tells you about other different types of topics, what kind of exercises you can do, what type of supplements that you might want to take to have better improvement in pain, how you can be able to look and evaluate different contexts of regenerative medicine versus interventional pain techniques. And those are things that I think are important, because it takes the control out of someone else telling you what to do and lets you be empowered to understand how, what, and why you should be able to do the various different solutions that we've talked about, and whether it's a fit for you versus not. Again, we want to encourage you to consider looking at how to be able to figure out what different options are out there for you, and how to be able to punch pain in the face and get back to leading your life that you deserve. Next week, we'll actually have a really interesting guest that's going to talk about the foundation of a technique that really provides sustainable pain relief from a different way in a minimally invasive treatment option. So please stay tuned. And as always, please, if you find this video of value, hit the like button, share it with somebody that you care about. And we really appreciate you joining us. Thank you and have a great day.